Okay, hello everyone, and thank you for joining us for the Step Therapy Patient Protections in Texas webinar. My name is Amy Prentice, and I am the State Government Relations Manager for the National Psoriasis Foundation. For those of you that aren't familiar with NPF, we are a nonprofit organization dedicated to improving the lives of individuals living with psoriatic disease. So today we are here to discuss patient protections put in place around step therapy following the passage of SB 680, which will impact plans being issued or renewed on or after January 1, 2018. So before I get into the content, I'm first going to do a little bit of housekeeping, so bear with me. Okay, if you want to go to the next slide. I'm sure you saw on the invite this webinar is available for CME credits. NPF is accredited by the Accreditation Council for Continuing Medical Education, and NPF designates this live activity for a maximum of 0.5 AMA PRA Category 1 credits, and physicians should only claim credit commensurate with the extent of their participation in this activity. So compliance with that CME credit, I'm just going to go over some quick disclosures. I do not have any information to disclose, and Simone and Sheldon do not have any information to disclose, and Dr. Evans has disclosed that he is a speaker for both Celgene and AbbVie. He is a consultant for Celgene and a page manager for psoriasis at about.com. So what we're here today to do is to have a really robust discussion around step therapy, and as I said, SB 680. We think that this information will be beneficial to my fellow government relations professionals, patients, and providers. Because this is available for CME credits, we will be getting into some of the policy and some of the technicalities of SB 680. So because of that, we have reserved some time at the end of our presentation to go over any questions or answers. So as we go through this webinar, please feel free to add any questions you may have at any time into this chat section of your webinar toolbox there, and we will try our best to get to all questions. If anything is not answered, we will make sure to get in contact with those individuals after the close of our webinar to answer any questions that were missed. And so you are aware, within a few days, you'll receive an email from me that will provide you a link to the recording of this webinar, and you will also receive the PowerPoint presentation, which you'll see later. We have a few hyperlinks that may be useful for you for future use. So with that, I think we are ready to get into the content and get started in the actual discussion. So first, before I really get started, I wanted to, of course, thank our bill sponsors, Senator Kelly Hancock, Representative Greg Bonin, and of course, all of our coalition members, patients and providers that were there with us in Texas that really made the passage of SB 680 possible. I know many of you are on the phone with us today, so thank you for all of your hard work and efforts to make this happen. So to actually introduce you to our panelists, today with us we have Dr. Colby Evans. Dr. Evans is a native Texan. He completed his medical degree and residency in dermatology at the University of Texas Southwestern Medical Center in Dallas. He furthered his study with a clinical fellowship at the St. John's Institute of Dermatology. He's been published in multiple peer-reviewed journals. He's a fellow of the American Academy of Dermatology. He is the immediate past board chair for the NPF, and he's also a member of the American Medical Association, the Texas Medical Association, and the Travis County Medical Society. I'm sure I could go on, but we'll stop there for now. Next, we have Sheldon Metz. Sheldon serves as the National Multiple Sclerosis Society's district activist leader for the 12th District of Texas and is a member of the Texas Government Relations Advisory Committee. He's a graduate of the University of Arkansas and Texas Wesleyan University School of Law. He is a his full-time job is a U.S. history, government, and economics teacher. And over the past 2 years, he has advocated on both the state and federal level for step therapy reform. And last but certainly not least is Simone Seger. Simone is a registered lobbyist in Texas, and she leads the National MS Society's activist engagement and policy in Texas. Her notable legislative achievements are focused on health insurance reform, including increased transparency, the creation of an expedited appeals process, and of course, most recently, our step therapy reform. She has been active in policy and government for over 10 years and contributes to the Society's positions and progress on network adequacy and access to MS medication. So thank you all for being here today. So to start, we can go on to the next slide. I thought it would be useful before we really delve into SB 680 is that we take a minute to briefly go over, what is step therapy? And what exactly step therapy looked like in practice in Texas. So with that, I will turn it over to Simone.
Thanks, Amy. Hi, everybody. I'm really happy to be a part of this webinar. So step therapy is when a patient is required to try and fail on a lower cost medication before access is granted for the drug prescribed by the healthcare provider. Currently, plans can require a stable patient to switch medications to try a lower cost drug, require patients to try and fail on the same drug more than once, and there are no limits on how many steps a patient must go through or how long they must try the required drug before coverage is granted for the prescription that is best for them and picked by their healthcare provider. Currently, the only protection for step therapy before this bill goes into effect in 2018 is that step therapy cannot be added to a formulary mid-year. But other than that, like I said, the patients are really subject to a lot of potential damage from step therapy.
All right, thanks for that, Simone. So, we're seeing this being used more and more often by insurers, and it's become more and more arduous over the years for both patients and providers. So we thought it would be important to really show you these impacts on both patients and providers. We can talk about the details of step therapy all day, but until you hear these stories, you don't fully understand their negative impacts. So with that, I'm going to turn it over to Sheldon, who is going to share his personal experience and talk a little bit about why it's so important that we pass legislation such as SB 680. All right, go ahead, Sheldon.
All right, thank you. Yeah, my job is just to, I think, provide the patient perspective of how this impacts just regular consumers of healthcare. And that's kind of been what my story has been, because I've had the fortunate experience of going through step therapy now twice, because I just had to go through it again in July, which was surprising. So my journey with step therapy began back in November of 2012 when I first met with my neurologist to discuss treatment options for my multiple sclerosis. I had just been diagnosed. I didn't even know what MS was when I got diagnosed. And so going through all these different kinds of medications to try to figure out which one would be best for me was a difficult task unto itself. But I finally settled in on something, and in January of 2013, my neurologist submitted for the prescription Gilenya. It was an oral medication because I really didn't want to do injections. I was switching careers because I was self-employed at the time that I was diagnosed, and I aged off my parents' health insurance within a couple of months of being diagnosed. So I didn't have health care. So I had to switch careers, and that was difficult trying to find a job. And then I ended up trying to figure out which medicine to try to take with that. So I didn't want to mess with needles if I didn't have to, because I had so many other things changing in my life. And unfortunately, my Gilenya was denied, the prior authorization was, and I kept a timeline here just so I can show the amount of time that took place just to try to get around to getting to the medicine that I'm currently on. But 13 days is what it took to get the denial of the prior authorization. Then I was told that I'd had a 30 days appeal process, and so that would be up to another 43 days total of not taking really any medication as I try to figure out how do I try to get to the medicine my neurologist thinks is best for me? And to quote my neurologist, time is tissue when it comes to MS. So every day that you don't have it, my disabilities were increasing, my lesions were getting worse, and we're looking at more and more physical disabilities that I would have to deal with down the road. The appeal was denied after about 2 weeks, and that was when the denial letter said that I had to take a cheaper injection for 180 days before I could reapply for Gilenya. And so I decided to take Avonex, which is a weekly injection. I took it just because it was once a week. Who wants to do a shot every day? And one of the side effects for Avonex is flu-like symptoms. Some people have them worse than others. Unfortunately, I had them very bad, so I do my shot on a Friday night, and I'd have a severe case of the flu within a couple hours. And I would deal with that all weekend and then try to go to work on Monday, and I'd start getting better by Wednesday or Thursday, and then Friday it was time to do my shot. So I couldn't take that anymore, but I hung with it for 10 weeks. But unfortunately, that still wasn't the time necessary to be able to reapply for Gilenya, so I had to get on another injection. And so I switched to Copaxone, which was an everyday shot, which that took some time to be able to get that prescription through and have somebody come out and show me how to do the auto-injector and teach me how to use the medicine and everything. And I was on the daily injection for Copaxone when I was able to switch to a 40 milligram, which was 3 times a week. And that's what I took, and that's what I'm currently still on as I still try to navigate through. Unfortunately, the Copaxone is pretty difficult for me to be able to take. It causes muscle atrophy in my stomach. I'm running out of places to actually inject it. The only place I can do it left is in the back of my arm or sometimes in my stomach. But the needle will be in my stomach for over 2 minutes as the injector tries to push the medicine into my under my skin. So that's where I've been left. And then this summer, as I was in the process of trying to get away from Copaxone and get on to something else, I got a call saying that my prior authorization was denied for Copaxone, even though I had been on that now for going on 3 years. And they wanted me to take Latopa, which was a generic of the 20 milligram Copaxone that I was on previously. And the reasons for that are, the patent fell off, I guess, and they were able to now have a generic available, but it really was just a cheaper version of something I had already really been on in Copaxone 20 milligram. And I actually ran out of my medication during that process of trying to appeal the prior authorization. So I had to go to my neurologist's office, and they had to give me all the samples they had in the fridge of the 40 milligrams just to get me to the point where I could try to get more medicine. And that appeal was actually won, and I'm still on the Copaxone 40 milligram. And I recently had MRIs on my C-spine and on my brain, and they came back pretty bad. I have lesions on my spine, I have lesions in my brain, and they're pretty prevalent. My neurologist, they said my MS is aggressive, which is always what you want to hear. But it just shows that this whole time that I've been on this medicine and I've been struggling and trying to figure out which one works for me, I'm not getting better. In fact, I'm getting worse. And I'm looking at physical disability now. It's in my spine. And so I'm in the process of trying to get on to Ocrevus, which is a newer medicine that's an infusion. And that, of course, has step therapy attached to it. So we're navigating that process now. It's been over 2 weeks, and I haven't even heard of whether or not I'm going to be able to get that medicine. So I'm still plugging away with the Copaxone and trying to make that work as best I can. So I think a couple of things, just to kind of conclude, I feel like I'm taking a little too much time, but the reforms that are in this legislation would have made a big difference for me, because I've experienced where I was forced to take off a therapy that I was on for several years to try something else, only because it was cheaper. And then also the time delay, all that time that is spent and all those weeks go by where I'm not on a medicine that's working for me. MS, like other diseases, the medications don't work for everyone. They're not substitute goods, I guess. One works for some people and one works for others. And the ones that I have been on aren't working for me. The problem is that I don't have control over the process as to whether I can get to medications that would actually help me. And the arguments that I've kind of made in sitting with elected officials is that, yes, it's a sad story because I'm still not on the medicine I want, even though I was diagnosed way back in 2013. But the longer that I go without this, if we're looking at saving cost, the more disability I'm going to have. And I have had increased disability. And that's going to affect my ability to work. That's going to affect my ability to pay taxes because I won't have a job. And so these things add up. And although it initially seems like a cost saver at the beginning, my costs are going up for sure. And the costs, I guess, to society as a whole are going to increase because I'm not going to be healthy enough to do things. And once you've lost whatever you have with MS, there's no getting it back. And so that's kind of the scary, I guess, point of it. I guess I'm in limbo now. We're going to see if I can get onto the Ocrevus. I've had the Avonex, Copaxone 1, Copaxone 2. They try to put me on Glatopa, and we will see. We'll keep on fighting. But that's why this legislation is so important for people like me, because my life is unpredictable enough with MS. You never know when you're going to wake up and be blind or not be able to walk, and it's frustrating to get a phone call that says, oh, by the way, you can't have your medicine either. So deal with that. So I'm very appreciative to everybody who supported this because it is such a big thing for people like me. So thank you.
All right, thank you, Sheldon. We appreciate you sharing your story, of course, and I know you've done this at the Texas Capitol, speaking with lawmakers and testifying at committee hearings and writing op-eds. So you've really done a great job kind of putting a real face and story to these negative impacts of step therapy. So I appreciate you taking your time out of your day to share with us, what you've been through. So on that note, now that we've covered, what a patient goes through because of step therapy, we're going to talk a little bit about how step therapy impacts a provider and their practice. So with that, I'll turn it over to Dr. Evans so he can share a little bit about what he faces dealing with step therapy.
Thank you, Amy. I really appreciate being with you today. I think Sheldon's comments are incredibly important and show us why the most important perspective, we needed a change in step therapy and the amount of suffering that is associated with not being able to access the best treatments that we have available. And I would reiterate something he said that we also see in psoriasis and psoriatic arthritis, where people can have permanent joint destruction. And probably all of you have met someone with rheumatoid arthritis who has the claw deformity and can't move their hand anymore. And we have drugs now that can prevent that from happening, but if the patient can't access them, then they have increasing levels of disability while we sit around and wait. From the physician perspective, of course, we want to be in team with our patients, and we want them to have the best therapy that fits with their specific disease and their specific life. And that, of course, is not the same for every patient. So a one-size-fits-all strategy is not successful. And the AMA, the American Medical Association, did a survey of physicians and found that physician offices were doing on average 37 prior authorization requests every week, and that was consuming 16 hours of practice and staff time. So that's staff that can't be talking to patients or helping the physician see patients, just doing paperwork. And unfortunately, most offices had someone who quit just because they didn't sign up to do paperwork all day, which was unfortunately has to be the job now in bigger practices, often of several people. So that we're clear, the purpose of step therapy is to prevent paying for medication. You will sometimes hear arguments that it's about making sure it's the right medication, but that simply, in my opinion, is not true. The purpose of it is either to delay access to medication, which we heard about in Sheldon's case, or in many cases to just deny it, because if the patient can't access it, they may disappear from the process, they may give up and become disheartened, and then the payer is not paying for anything, which, of course, from a financial perspective, is their goal. So we always want to push back against step therapy whenever we encounter it, because its fundamental purpose is not to help the patient. I think another thing that's really important to know is that logic does not play a role in thinking about step therapy. The cheaper drug is not always the preferred drug. If you think about it logically, you'd think if there was a $100 drug and a $200 drug, that they would want you to fail the $100 drug before you could have the $200 drug. But in reality, if the manufacturer of the $200 drug is giving them a $110 rebate, then they're going to choose that drug as the first drug, and you'll have to fail that before you can have the $100 drug, because it's really about what money ends up in whose pockets at the end, not about the science or what is best for that particular patient. And as Sheldon's story indicates, we need the full panoply of choices, because patients have other diseases, they have other health issues, they have other work and social issues, and so one specific drug won't always be right for a given patient. And I thought it was important to take a moment to talk about pharmacy benefit managers. That may be a term that some of you have encountered, or you hear the term PBM sometimes. And there are 3 of them that represent about 80% of prescriptions in the United States: OptumRx, CVS Caremark, Express Scripts and CVS Caremark. And those are middleman companies between the insurer, the manufacturer of the drug, and the patient. And that started back in the 60s when insurers started paying for a whole lot of prescriptions, and so they began hiring these third-party companies to manage all of that for them. And the pharmacy benefit managers are the ones that get these rebates. And so, perversely, they often want to see the price of the drug go up, because the higher the price of the drug, the bigger bite they can take out of that price to get a bigger rebate. And so sometimes we see perpetually increasing prices as we get more and more restricted formularies of access to medications, because it's not about the drug, it's about who is getting a chunk of that payment along the way. And unfortunately, that process is not transparent. So we don't know who is paying who and how much, so that we could say, well, okay, this makes sense, or this doesn't make sense. The process all happens sort of in a black box. So from the physician perspective, it's very frustrating, and probably second only to the frustration the patient feels, because we want to get our patient treated. We want our staff to be taking care of patients and not filling out paperwork. And it's a long process. You often start with a prior authorization request after you've written the prescription. That's denied. Then you begin the appeals process that Sheldon described. That's denied. And then you sometimes move on to a peer-to-peer interaction, which is where I call another doctor who works for the insurance company and explain why I want a specific drug. And that doctor is often not a dermatologist. They often are totally unfamiliar with psoriasis or any of the treatments, so it's hard to understand how they can make an informed decision. But if that is denied, then we're left with following the steps of step therapy. And I am really excited about SB 680. I think it will have a big impact as we get into the next couple of years and plans start being covered by the law to help limit some of the most egregious examples that we've seen, like in Sheldon's case. I'll turn it back over to you, Amy.
All right, thanks, Dr. Evans, and I appreciate you sharing your knowledge of, which is very informative, in your experience with step therapy with us today. And like Sheldon, I know you spent a lot of time in Austin, providing your support for SB 680. You were a speaker at our press conference, and we're there always helping make our efforts successful. So thank you for that. So with that, now that we have gone over, step therapy, the impacts on both the patient and provider, we're finally going to kind of get into the nitty-gritty of what our bill does and how we hope to address all those negative impacts we've just heard about. So with that, I'm going to turn it over to Simone, who is no better person really to talk to you about SB 680. She helped lead our coalition's efforts in Texas and was there on the ground negotiating this language with our bill sponsors and health insurance plans and all stakeholders, and did a really wonderful job at getting some strong language put into place. So with that, I will let Simone take it away.
Thanks, Amy, and thanks to Dr. Evans and Sheldon and Amy, you as well, for everybody's role in making sure that SB 680 passed. And so SB 680 does a lot of really great things. And if we could get one slide forward, please. Oh, one slide back. Sorry. Okay, that's okay. So the SB 680 does a lot of great things, and it applies to plans that are regulated by the Texas Department of Insurance. And so it's really easy for you or your patients to know if you have a state-regulated plan. Look at your insurance card, and in the bottom left corner, if it says TDI or DOI, you have a state-regulated plan, and these protections will apply to you or your patients. So I want to dive into the bill. So SB 680 first requires insurers to consider widely accepted clinical practice guidelines when establishing their step therapy protections. So Dr. Evans referenced this, that there's really no medical rhyme or reason for why the steps are indicated in the order that they are. And so step therapy, SB 680 helps address this. In the absence of up-to-date clinical practice guidelines regarding prescription drugs, like in the case of MS, insurers now must reference peer-reviewed publications developed by independent experts. So, for example, the American Academy of Neurology. So basically what all of this means is that insurers now must consider actual medicine and not just cost when creating the protocols they require their enrollees to use. Next slide, please. However, if the patient would be harmed by step therapy, SB 680 also created a transparent and expeditious process to appeal or to request an exception and then appeal a denial of step therapy. So this applies to all healthcare providers, not just physicians. And healthcare providers can use the Texas Standardized Prior Authorization Request Form for Prescription Drug Benefits, which is linked here, to request a step therapy exemption. An exemption should be granted if the drug required under the step therapy protocol is contraindicated. So, for example, if a patient is pregnant and the drug is not safe to use during pregnancy, will likely cause an adverse reaction or physical or mental harm to the patient, is expected to be ineffective based on the patient's unique history and condition. And then the bill also protects patients from having to try and fail on the same or even similar drug more than once, even if they switch insurance companies. Next slide, please. A step therapy exemption should also be granted if the healthcare provider believes the insurer-required drug is not in the best interest of the patient because it would create a significant barrier to compliance. And so this sort of references back to Sheldon's story. So for a patient who has severe needle phobia, who might be required to try an injection before they are allowed to access an oral drug. So that would be considered a significant barrier to compliance. Would worsen a comorbid condition, so you wouldn't want somebody who has high blood sugar to be required to try a drug that causes weight gain, or decreases a patient's ability to achieve or maintain reasonable functional ability in performing daily activities. So for example, it would be inappropriate to ask an airline pilot to try and fail on a drug that causes severe drowsiness. Finally, the bill protects patients whose conditions are well controlled on a medication from being required to try a new medication, even if step therapy is added to the formulary at renewal, or they switch insurance companies. We really don't want a patient who is stable on their medication to have to try something new and risk disease progression or relapse. Next slide, please. So once a health plan receives the form requesting the step therapy exemption, they must respond within 72 hours. So in the cases of an emergency situation, they have 24 hours to respond. And should they deny the step therapy exemption request, SB 680 ensures that it would be considered an adverse determination and therefore eligible for an expedited external appeal by an independent review organization, or IRO. Next slide, please. So the form to request the expedited IRO review, and by the way, this would skip the internal review with the health plans completely and go directly to the final external review, is linked here. However, because this expedited appeal process has been step therapy has been added to this expedited appeals process, the Texas Department of Insurance is in the process of updating this form. And so they will be posting it at this URL, it's linked here, in mid-December. so that the step therapy exemption appeal can be requested from this form. The expedited IRO appeal must be decided within 72 hours of receiving all relevant documentation, and in the case of an emergency, they must make a final decision within 24 hours. So I just want to say again that this is an incredibly strong bill. In addition to requiring insurers to consider medicine, not just cost, when establishing their step therapy requirements, creating a clear process so that healthcare providers know exactly what would qualify a patient from being able to be exempt from a step therapy requirement, and ensuring that there's a standardized form to request the bypass. It also creates this expedited timeline. So Sheldon alluded to the amount of time that he spent appealing and filling out the prior authorization forms and waiting for an answer. And so the maximum amount of time that this entire process could take prior to SB 680 going into effect in January is 53 calendar days. It is now, can take as, well, not now, in January, it can take as little as 6 days, and in the case of an emergency, even less. I'm happy to discuss this bill. I know I went through that very, very quickly, and it was very technical and maybe a little bit dry. But I'm happy to discuss the bill in more detail, so should you have any questions, please don't hesitate to ask. And then we also really intended and worked hard to make sure that this process is transparent, that it's expeditious, that it's easy for the patient and the healthcare provider. So if this isn't your experience as you work through this process starting in January, please let us know so that we can address it. So thank you, Amy.
All right, great. Thanks, Simone, for that really great overview of SB 680. So you can go ahead and flip to the next slide. All right, so obviously, you know, at the heart of our bill is this exception process that patients can, you know, get around these step therapy protocols if it's not medically appropriate. So what we have here on the screen is that prior authorization form that Simone mentioned, which is surprisingly only 2 pages. So what I want to do is give Dr. Evans a moment, one, to talk about how he thinks these exceptions will benefit his patients, and also kind of to touch a little bit on this form and what type of documentation or anything in that regards, and how he would best submit an exception request.
Thanks, Amy. I think this is exactly at the heart of what we need, a chance to go to independent review if we're not getting appropriate options for the patient. I also want to remind everyone of something Simone said, that although January of next year is the start of the law, it's when the plan turns over. So if your plan doesn't renew until July or something, these may not kick in right at the first of the year, and there may be a kind of a staggered kick in over the next year. Any physician or physician's office is going to be intimately familiar with forms like this. We fill these out every day, usually, as you alluded to, much longer ones. And it'll contain simple information about the patient, about what medications they have tried and failed, and what other conditions they might have, as Simone alluded to, that might preclude a certain medication or favor a certain medication. And what we found in other states that have passed this law is physicians are not always aware of the law, and sometimes even insurers and payers are not always aware, or their staff is not. So it's very important to communicate that you are filing for an appeal under this specific law, and you can have stickers printed up that say SB 680 and explain, you know, this is requesting an expedited review of the step therapy exception. You can write that in the comment section that, you know, under this new Texas law, I'm requesting review, and that's required to be completed within 24 hours or whatever the specific case may be. But that, watching them as they go through and communicating to everyone involved that there is a change in the law is really important, because if the physician doesn't know that, they may not understand they have this opportunity for expedited appeal.
All right, great. Thanks so much for that. So before we get into question and answers, our question and answer portion of the show, which, you know, as a reminder, go ahead and please feel free to submit any questions you may have. I wanted to take a minute, to say that, Texas is not unique in this type of patient protections. If you flip over to the next slide. What I've provided here is a map showing you, one, which states have already placed similar patient protections into statute, and also states that we are targeting to do legislation similar to Texas. So this has really been a movement that's been happening for the last few years, and there are coalitions all around the nation that are working to get to reform step therapy protocols. So I would, if you're interested in any protections that are already in place, which you see there in blue, what you can do is you can reach out to me, or you could visit steptherapyinfo.com, where we have a map that will show you, what exactly what protections there are and how to use them. And if you, are an organization that, maybe has a presence in any of these states in orange that are looking to do something similar next year, or maybe you have, a family or a friend that would like to get involved in any of these orange states, please do not hesitate to reach out. We're always looking for people to support these step therapy reforms. So beyond the state level and this movement shown here on the map, there's also been some federal attention. So you go to the next slide. There has been a bill introduced at the federal level, which is HR 2077, called the Restoring the Patient's Voice Act of 2017. And what that does is it tries to improve step therapy protocols in a way that is very similar to the Texas bill, by establishing that clinical review criteria, by providing that exemptions process, and then that time frame for responses by insurers. So there is an effort to get this passed federally. This was introduced by Congressman Brad Wenstrup in Ohio and Raul Ruiz in California. We have a way to submit a support letter. You'll see there that's hyperlinked. Just to make you aware, this hyperlink is Texas specific. So what the coalition has done in this effort federally is they have reached out to all these states that you saw there in blue on the previous map that have passed step therapy legislation at a state level, and asking those lawmakers to appeal to their federal congressman that, hey, there's this bill here, you should do something similar to what we've done. So this is a Texas specific letter. We do have Texas letters set up for other states that we'd be happy to share. But if you have any other questions about this effort, or want to get involved in other ways, you can reach out to Jessica Negro, who is our Federal Government Relations and Health Policy Manager here at NPF. And I've provided her email there at the bottom. So that takes us to Q&A. So bear with me while I pull up some questions here. Okay, so it looks like we have done such a good job in providing well-rounded and thorough information. We do not have any questions. So that really brings us to the end of our content for today. If you do think of any questions at a later date, please do not hesitate to reach out. Kate, if you want to go to that last slide, I've provided my contact information as well as Simone's. And again, as a reminder, we're going to send out an email within a few days that provides a link to this recording, as well as our PowerPoint, that you'll have access to all those hyperlinks. So everyone that has joined us today, thank you for bearing with us and listening to all this really important information, and we hope you found it very useful. And thank you for all my panelists that have taken time out of their day to really provide this wealth of information that they have. And thank you so much, and enjoy the rest of your day.
Thank you, everyone.
Thank you.
Thank you so much.